Everyone. My name is Frank Ofosu, and I'm here with my colleague,
Oscar Odera.
All right. So today we'll walk you through our project titled FHIR-Based Prediction of Hospital Readmission for Patients Aged 50 plus. Our work focuses on leveraging artificial intelligence and structured healthcare data to support early interventions and improve patient outcomes. Okay, so hospital readmissions, especially within 30 days of discharge, are a major concerns both for patient health and hospital systems. In this project, we will use AI to predict the likelihood of readmission by analyzing clinical data structured in FHIR format. So now the FHIR is fast healthcare interoperability resource. And then this allows clinicians to intervene early patients who are at risk of unnecessary readmissions. Well, a little bit about our literature review. Traditionally, tools like the LACE index and hospitals score have been used to estimate readmission risk with limited predictive power. But machine learning has improved this by incorporating more variables like lab values and commodities. However, there is still a gap in integrating these models into clinical decision support system, especially with data standards like FHIR. One of the recent studies from Michaelides obtained an area under the curve, an AUC of 0.78 by utilizing a random forest classifier, which with administrative and clinical, medical, and operational data, which AUC performed much better than this research. Okay, so with our problem statement, high readmission rates can disrupt recovery and increase complications. Well, they also bring financial penalties for hospitals. And then current models don't account for complex interactions in patient data. But our research addresses this by building a more accurate, interoperable AI model using FHIR resources. Okay, so when it comes to the population chosen, we focused on patients aged 50 and above with chronic conditions such as heart failure, COPD, and diabetes mellitus. You realize these individuals face a higher readmission rates and care complexity, but FHIR data offers rich detail like medication patterns and lab trends, which is perfect for the modeling, perfect for modeling their risk accurately. All right.
Okay, now we get into the code that we use to help us do the prediction. First, we developed this script that enables us to load the initial data set. So we first did Python script that writes the FHIR-JSON data into a CSV so that we get baseline data, which we enriched further by reading timestamp directly from the JSON files to make it do the 30-day prediction. So after initial loading, we went ahead and did feature engineering that included condition counts, comorbidity indices, and laboratory value statistics, and also implemented the time-based by directly getting the timestamps. So after that, we included a column for prediction readmission and labeled 320 patients as 0 and 158 as 1. as can be seen in our code snippets that are in the presentation here. Before that is done, we understand that the project leveraged on existing data within MTU structures research, like the CCDA, ADT, which are in raw format. So again, we leverage on Python scripts to make them FHIR compliant at first. Then after that, we went ahead now to bring the models in to do the predictive analysis. So this shows the conversion steps, how we did the validation to ensure FHIR compliance, how we aggregated the data into CSV, and now went ahead to extract the various features that are necessary in doing the prediction modeling. When that happened, our code gave us results which are way better than what exists in previous research like the Michaelis. So the models that performed better include Random Forest, which had 0.86, which is 86%, and gradient boosting, which gave us AUC of up to 0.87. We will do that practically when we get to the code. So out of that, we realize that the features that are most important in doing readmission prediction with the data we had is commonly heart rate, number of conditions that are present there, systolic, blood pressure, temperature, diastolic, weight, height, age, which enable us to get the BMI and also glucose levels. So those 10 features were found to be very important in doing the readmission prediction. Then the logic of our findings clearly indicates that the laboratory values, particularly trends in heart rate and number of conditions, were among the best, as we have said. Then the best performing models were the ensemble models. And also for model evaluation through the AUC, we had better recall and accuracies, which we will see in the code predictions. Then the last slide of our presentation just shows some of the resources we used to build up our project. So generally, that was our project. We are open to doing any other enhancement that would make it better and include it in the CDSS, clinical decision support, that it can be used to do readmission prediction to enhance patient care. Thank you.
Thank you for your attention, and we are open for questions and discussions on how this work can be scaled or integrated into hospital systems.
Good.